Hi, I'm Ellie Dehoney. Hopefully I know a lot of you in the audience. I'm the Senior Vice President of Policy and Advocacy at Research America. And I've got to say, it is a hard act to follow, that last panel discussion on mental health research. If you missed it, we'll have the recordings after this. And it was terrific. As will this discussion be. We're talking about actually a serious topic, and that is the Inflation Reduction Act, which was passed into law about a year ago now. And I think, I don't know, I bet a lot of you are familiar with this legislation. It was pretty sweeping legislation. We're focusing on a couple of the provisions that definitely impact patients and related the pace and direction of medical progress. And these provisions do that in complex ways, and I'll say controversial ways. And that's why I am relieved that we have two experts here for this discussion to talk about those provisions. So Matt Kazan is with Avalere Health, one of the top, if not the top, health policy consulting firms in our nation. And Matt is an expert in Medicare policy and many realms in that arena. So very relevant to today's discussion. Randall, or Randy, Rutta is the CEO of the National Health Council. And the National Health Council is an amazing cross-sector organization that has a focus on patients' role in the coverage and research arena, and making sure they are front and center in decisions bearing on their future. And since we are all patients, Randy's role is significant for each and every one of us. I am not going to take a lot of time blabbing, but instead turn to our guest speakers, starting with Matt. And wait, let me just stop to thank you both, if I haven't done that already, for joining us. And Matt, let me turn to you.
Of course. Well, thank you, Ellie, and thank you to Research America for the invitation to speak to you all today. As Ellie mentioned, I'm going to speak for a few minutes about the Inflation Reduction Act, and in particular, the prescription drug policies that was included in that law, as well as talk about ongoing implementation and where patients and other stakeholders could perhaps influence the debate and provide their input into CMS as they implement this really landmark law and changes to the Medicare program. So let's level set a little bit, if we advance the slide, to the provisions that I'm going to focus on. As Ellie said, the Inflation Reduction Act is a huge law that covers more than healthcare and even more than drug pricing policy within healthcare. I'm going to focus on three particular provisions that I think are important to talk about today. The first being Medicare negotiation, the second being a restructuring of the Part D benefit, and then the Medicare prescription payment plan, which seeks to improve affordability for Medicare patients in Part D. One thing to note before we dive into the substance is that this law is being implemented in a slightly different manner than laws are normally implemented. Usually a law is passed, signed by the president, agencies put out a big formal federal regulation that's open for comment, they finalize it, and then the program starts. Because of the complexity and the timing of this law, CMS is implementing it through kind of sub-regulatory guidance documents, and they're coming at us often and fast, and it's hard to keep up. And so that's why it's, I think, really helpful and great that we're having this conversation around where there are opportunities to engage with the agency. So let's dive into the substance of each of these. I won't go into too much detail because we don't have a lot of time, and these get complex, but just at a high level, what do these three provisions do? The first, Medicare negotiation, allows for the first time for Medicare to negotiate directly with certain drug manufacturers for certain drugs. Not every drug, certain drugs. The law requires that drugs that are eligible to be subject to negotiation have to be on the market for a minimum period of time, lack no competition from a biosimilar or a biologic, and Medicare has to spend a lot of money on those drugs. Those subset of drugs are eligible for negotiation, and then CMS every year will select a specific number of those drugs to be subject to negotiation and ultimately reach a price that Medicare will reimburse for that particular drug. We'll go into a little bit more detail on where we are in that process here in a second. The other two provisions that I wanted to touch on, Part D benefit redesign. This is a provision that's going to affect every stakeholder that touches Part D. For the first time, it will introduce an out-of-pocket cap for patients where there does not exist one today. And then stakeholders like drug manufacturers and health plans will have to contribute more financially to the Part D program, whereas government spending will be reduced. And then finally, the Medicare prescription payment plan, or what's often referred to as out-of-pocket smoothing, allows beneficiaries, rather than pay all their cost sharing upfront at one point in time at the pharmacy counter, they would be able to spread that cost over the course of the calendar year, much like a payment plan that you see in other settings. These are probably the three biggest provisions that impact patients directly. And so want to talk a little bit about where we are in the implementation of each of these and where there are particular opportunities to provide input to the agency by patients, by patient groups, and other stakeholders. So let's advance one more slide. Obviously not going to go through all this, but this is just illustrative of all the deadlines and things going on dealing with implementation of this law. You can see that star on the left-hand side of the slide. That's where we are today. Each of these three provisions have numerous deadlines and implementation kind of benchmarks that CMS is living through. So I'm going to try to dive in on a couple key ones that I think are important to know about as we look forward to full implementation of the law. So let's advance one more. So let's start with Medicare negotiation. As I said, a certain subset of drugs covered by Medicare are eligible to be selected for negotiation. CMS, only a couple of weeks ago, released the list of the first 10 drugs that will be selected for negotiation. And it is, if you do meet the criteria, then CMS looks at total Medicare Part D spending for those drugs, and they selected the top 10 drugs by spend. And you can see those drugs, as well as the manufacturers of those drugs, are listed here, as well as the total amount of spending. If we advance to the next slide, you can see that there are certain therapeutic areas that are affected. There's a little bit of overlap depending on the particular drugs, but TAs like autoimmune, cancer, cardiovascular, diabetes, heart failure, et cetera, these are the TAs and the specific drugs that will be affected for the first year of negotiations, which the negotiation process starts here in a couple weeks and will be effective starting in 2026. So a lot's going to happen between now and 2026. And so if we advance one more slide, I think we can focus on a couple of key areas where stakeholders can engage with CMS. So obviously there's an opportunity for stakeholders to meet one-on-one with CMS and CMS officials at any point in time. And we would urge stakeholders to take advantage of that. CMS has also established two kind of formal processes by which stakeholders can provide their input. The first is around data submission. CMS is required to take into account a bunch of different data types when they are going through the negotiation process and ultimately setting that price that Medicare will pay at the end of this. Manufacturers that you just saw on the screen have to submit data, but also other stakeholders have the option to submit data as part of information collection requests. And so that's noted on the slide here as the number 2 star, and there's a deadline for that. CMS also, when they released the list of drugs, announced that they will be holding public patient listening sessions during the negotiation process in October and November. And so that will be open to the public. CMS will select a set number of groups and stakeholders to participate. And so that's another way in which stakeholders can discuss the potential impact of negotiation on patients, on these TAs, and provide suggestions for what CMS ought to contemplate throughout the negotiation process. If we advance one more slide, I want to hit on Part D redesign, which is another impactful policy that's going to affect patients as well as other stakeholders. This is likely to be implemented very similar to other changes to the Medicare program, where we saw some guidance early in the this year that was open for public comment, and they will finalize that guidance. But I suspect most of the big changes will be proposed in a formal regulation that will be released in the fall and then finalized in April of next year. So, and all those changes would take effect in 2025. So things like plan rules, formulary design, implementation of the out-of-pocket cap, those things will be contemplated for this fall. So that's, and that rule is sitting at OMB right now. So we expect that to be released in the coming weeks. And that's something that folks will want to pay close attention to and potentially respond with formal comments to the agency. And then finally, the out-of-pocket smoothing provision, or MPPP, as it's been named by CMS. This is a provision that will be implemented via this sub-regulatory guidance, and actually in two different guidances. So CMS released a guidance a couple of weeks ago on implementing the program with a whole host of important issues around, can beneficiaries sign up for this program at the pharmacy counter, or will they have to go through their health plan? What beneficiaries will be required to be notified by pharmacies and health plans about this new option, and a bunch of other kind of operational and policy issues that CMS needs to decide before 2025. CMS also expected that a second guidance will come out at the beginning of next year. And the focus of that guidance will be, how should CMS talk to patients about this program? And so to the extent that stakeholders have a view on outreach and communication for this important program, that's something to watch out for and engage on in terms of comments to the agency. And again, this program, similar to Part D redesign, will take effect in 2025. If we advance one more slide, just to wrap up, and I know that was super quick, and happy to take questions to the extent that we have time. A couple of suggestions that we have in terms of outreach to CMS when you think about IRA implementation. Understanding these kind of key deadlines and what issues are at stake is obviously table stakes when wanting to engage with CMS. We also recommend that stakeholders align with similarly situated stakeholders, coming to CMS with a unified front about what the issues are, what the policy recommendations ought to be, is going to be much more powerful than kind of one-off requests that are scattered throughout the industry. And then three, specificity, right? This is a law that's being implemented on the fly, so to speak. And so CMS is going to really appreciate very detailed and specific requests and proposals so that they don't have to do as much work as they otherwise would have. So to the extent that you have a fantastic idea about how negotiation should work, or how patients are going to be impacted because of a specific drug that was selected, the more specifics you can offer the agency, I think the more advantageous that's going to be for your particular interests. So Ellie, I know that was a lot. I went very quickly. Happy to answer questions, but I wanted to leave a bunch of time for my good friend Randy, who I'm sure has some fantastic thoughts to share on how the NHC is tackling the IRA.
Absolutely. I don't think anybody has accused health policy of being easy or straightforward. You know, one thing that struck me in your presentation is that it feels a little bit, the whole thing feels a little overwhelming as a patient. I am a patient. So, you know, I think the heart is important here too, you know, in a sense that I think CMS does need to hear the detail, but they also need to hear the sense that, you know, every drug you look at is important. It needs to be affordable to me and accessible to me. And this is why, because what this all comes down to, the brass tacks, is that it affects us on a day-to-day basis. So that was just a little side note. And now I'm going to turn to Randy, my favorite patient advocate in the world. And Randy, your perspective is going to be so valuable here. Over to you.
Well, thank you so much, Ellie. Thank you to Research for America for continuing to put together wonderful opportunities for us all to come together and really address the topics at hand that are so critically important to us as individuals and to the communities we represent. And Matt always sets a high bar for understanding. So what is that opportunity? And oh my gosh, what's that timetable? And so, yes, a little bit of feeling a little overwhelmed is probably warranted right now. In some ways, it's like, be careful what you wish for, because the IRA, and I don't think as it evolved over the course of several years and then that final push, was necessarily as inclusive as all of us would have wanted it to be, because the stakes are so high for patients and our patient stakeholder partners. But yet, that legislation emerged and CMS caught it. We know many of the individuals there. And I think that's something that, we can appreciate. And so it's like, so where are we now? And I think Matt provides a really good framework for that. So I'll focus on kind of the things that he touched on and then really zero in on the opportunity that exists within the Medicare price negotiation, because that so much is at hand. So, as I say, leading up and then really since the IRA's passage, the National Health Council with all of you has consistently urged CMS to engage patient organizations and patients in understanding the process, so what's happening, and contributing our perspective to the medicine selected for negotiation, and to continue to influence those other parts that Matt just described, all incredibly important. Any one of these initiatives, had they emerged as a single piece of legislation, would have kept us very, very busy and would have reflected a culmination of years of advocacy. And now here we are on these multiple fronts. But, what we know is patients have an enormous stake in access, affordability to the treatments that support their health and well-being. As you mentioned, Ellie, Matt also said that, we're deep into discussions about the Part D redesign and the Medicare prescription payment plan. Also incredibly important to how it is patients will, have access to and adhere to the medicines that are going to keep them healthy and in their jobs, in their families, in their communities. And so incredibly important. I'm going to kind of zero in because I have that sense of urgent focus on responding to this opportunity to inform and influence this inaugural drug price negotiation process, just to as a starting point. So, why is that important to all of us? What are the reasons for meaningful patient engagement so critical to the process at this time? Well, we know that CMS, as Matt said, is tasked with developing a maximum fair price, which should depend on how well a product meets the needs of patients who take them. Well, as you just said, Ellie, the best way for CMS to understand that, for our system to understand that, is to talk to patients. And as we know, sometimes as you come through the clinical trial process, as we market and go to, make these medicines accessible, we don't always touch back with patients to say, so how is that medicine working for you? Are there aspects of that really support you in your life? Are there conversations you're having with your physician about alternatives because of what's out there? All of that gets woven into that personal experience that patients have with the therapies that help them both diagnose and then sustain their health. And I think the more involved they are, the better they can understand why they want to adhere to those regimens of treatment that are so important. So hearing directly from patients is critical. Manufacturers, I believe, should also be rewarded if they can demonstrate that a medicine's benefit to patients really has taken that full patient voice into consideration. That this will further encourage patient-focused drug development. We know has been so successful in putting patients at the table when thinking about these therapies and how they involve. And that's been, as you know, a priority for the National Health Council for more than a decade. As we know, meaningful patient engagement in the price negotiation process comes at a really critical juncture, I think, for both public and private decision makers in adopting methods that involving patients in the decisions that affect their health. We have heard the phrase, and I think we all really feel it, in our hearts and souls. Advocates understand and champion that nothing about us without us is the only approach that's going to really be successful for an individual, for a population, and for the system itself. So the NHC is actively encouraging patients and patient groups to explore participation with CMS to demonstrate the value of incorporating patient perspectives in this effort and in other efforts that CMS is undertaking. work such as coverage decisions, payment models, quality measurement, some of the things that Matt was referencing. Patient engagement should be a given and automatically embraced in how it is that we get to the best decisions and ultimately outcomes that we all care so much about. Now, we recognize that there's room for improvement in the process kind of as it's laid out when we think about this first set of 10 drugs and how they'll be evaluated. We question a little bit about how that full value of the patient experience can be captured in those 3-minute, increments with only 20 patients participating. I personally have participated in some of those kinds of listening sessions and things, and it does really challenge you to try to bring the richness of your experience forward in such a short time frame. But that's our process. That's what we've been given. And so we want to make sure that it's as rich and meaningful as it can be. We also want to make sure that that process doesn't deny really these decisions the opportunity to understand the richness of diverse patients and the experience of patients that really can vary so much from one to another, even when looking at a specific therapy. So let's take that into consideration for this first round and as we go forward. With that said, I think CMS, was not required to include listening sessions or that kind of active outreach to patients. So we acknowledge that that really is a reflection that they do understand the value of having patients at the table. We appreciate the openness that CMS has had to meeting with groups and patient groups individually to talk about what is this process going to look like, how are we going to go forward, and so I think what's incumbent for us as a community then is to absolutely show up and really demonstrate the value of having opened the door for patient engagement, that we really take advantage of that. So we are encouraging our patient group members, patients, really every aspect of our community to be engaged in the process that CMS has laid out and that Matt just described to us. So it's so critical. We remain in constant touch with our CMS colleagues to, be supportive and support that process, understand how we can really make sure that a robust response takes place now and then sets the stage for the future. And it's just critical, I think, that we take advantage of this opportunity for decisions to be include patients. So we're present and we're informed, key contributors, for better patient-centric decision-making that results in outcomes that improve access, as you said, affordability, as you mentioned, ongoing discovery, and a more sustainable Medicare program. As I start to conclude, I'll just say the stakes are high. Consider these comments a call to action. If we as patient groups don't submit data or register to participate in the listening sessions as they're constructed, then we don't know that we'll continue to have that opportunity in the future rounds of other negotiations where future sets of drugs are then examined. But I would argue that could actually put at risk a lot of the progress we've made with the FDA or the NIH or CDC, where patients really have been invited to the table, and we've made the commitment and the point that it's so important to include patients. They'll be watching. Those agencies will be watching. The broader CMS community will be watching to say, wow, if the patients didn't respond now, maybe that's not as a technique that's as needed as we thought, as the patient advocates are suggesting. If we show up in full force and have a rich contribution to make to this discussion, I guarantee you that we will have more and broader opportunities in the future. So we're creating forums.
I'm so sorry, Randy.
What's that?
I just interrupted you only because I'm afraid we're almost running out of time, which can't be. Well, Sarah, can you join us and let me know, are we to wrap up at 11:15?
No, you still have till 11:20, so you have a good 6 minutes.
Oh, thank goodness. I'm so sorry to interrupt you, Randy. I just wanted to make sure we had time for I wanted to do a couple of clarifying questions.
I appreciate that, Ellie. I had one eye on the little ticker here.
And, you're better than me. You are so much better.
I think, because I know you're such a kindred spirit, it really is a call to action. Let's absolutely show up and take the best advantage as we can for and with patients, so that, CMS in this process, CMS in future processes, and in all the great work that they do, and other agencies know that patients have to be at the table, better decisions will be made, better outcomes will be achieved, and that this is our opportunity to do it. So as I said, we're going to be asking groups that participate in the process to share their experience. We'll build on that. We'll stay with the process through this first year as we start to plan for the second. I really encourage everyone who's participating to sign up, meet that October 2nd deadline. We've got some resources and materials that'll help you participate, and it will be an evolving process that I know will be an important one, and it will be a good one, and it will respond to your thinking of why is this session important in Research America's presentation. It's because this is a point in time where decisions are being made in a new way on a major public program that influences all of how healthcare is structured. This is our time to show up, be present, be counted, and taken seriously. So, Ellie, thank you for this opportunity.
Beautifully put. I have one question that is on the policy side and one question on the patient side. I think I'll start with the patient side in the interest of time. So I'm just wondering what's next for me. Let's say I'm listening to this, I'm a patient. Do I go to your website, Randy, to try to figure out how to participate? Do I go to Medicare's website? What would be your advice for me if I am out there and I just want to know how to help?
Sure. Well, definitely look at our website. We've created some kind of user-friendly materials, kind of cheat sheets, if you will, because there's a very—
Put that in the chat if anyone could get the National Health Council, if it's not already in the chat.
That would be great. And yeah, we've got, because the way in which groups can kind of stand up, or patients can stand up to register to participate in those listening sessions, is very specific, and very specific information has to go in. So we have kind of a cheat sheet that helps people navigate that.
Wonderful.
And and then also a lot of what Matt has shared and other kind of resources that are there. Matt may have an idea, though, that if someone did go to Medicare.gov, what might they find there that would be really good information as well?
That's great. I think an example, if you if you haven't done research on QALYs, this is the kind of, it's really hard to measure the kind of the value of a drug or any kind of a medical product without some kind of a metric. And one that's frequently used it's called QALYs. And please don't ask me to tell you what that acronym means, but look it up. It's a rough measure in the view of some patients. And so the more we can come in with detail as patients beyond QALYs as a measure of the value of different medicines and products, the better. So I really encourage you to kind of do some legwork and research on this, and weigh in, and get in touch with me, get in touch with Research America, get in touch with the National Health Council and Randy if you want to talk through this further. Matt, a quick question. One of the controversial issues about the Medicare negotiations, and Research America, again, hasn't taken a position. We just want the complexities of this out there. There's some differences in the way different drugs are treated, different types of drugs, for example, oral versus biologics, orphan drugs versus other drugs. But the negotiations are actually, if a drug company doesn't accept that final price, there's an excise tax, something is actually imposed to make sure that they accept the price. Is that right?
Correct. So there's a number of requirements on manufacturers that are selected under negotiation. And those manufacturers have a very difficult decision to make. They participate in the negotiation program. They can exit the Medicare and Medicaid programs altogether. And if they do choose to participate in the Medicare negotiation program, but then don't abide by the rules every day in which they are, quote, out of compliance, they pay an excise tax to the government per the law.
Perfect. And the reason I raise that is, again, not to take a position, but to say, if you feel like the word negotiation is benign, like we negotiate every day for everything, it's not exactly a negotiation. And so I really encourage you just to learn more. Research America, that's what we're here for, if we can help. And I think we're at time. So what I need to do now is, Randy, Matt, thank you so much. This has been quick and informative, and you both are great partners with Research America. And let me find my cheat sheet. I know, next step, join us in the lobby. And that's where you can log into the next session on infections and climate, which is becoming a really hot topic. So I encourage you to join us. And thank you so much, you guys, and see you both soon.
Yes, you will. Thank you,
Okay,
Ellie.
thanks for joining us at this forum. Bye.
Bye-bye.